on the best of ASH implications for the treatment of MDS on behalf of the MDS Foundation. And so I'd be happy to take questions during the course of the lecture or at the end via chat or online directly. So why don't we begin? This just gives you a background on the target, the program information, the target audience, and then the learning objectives to become familiar with the state-of-the-art of hypomethylating agents and novel targets in patients with MDS. This is for a broad array of medical personnel who can participate and receive accreditation. These are disclosures as part of this presentation. And here are the objectives for the presentation. Again, to understand what the recent data on somatic mutations in patients with the MDS, understand the science of hypomethylating agents, and discuss some novel targets in trials. I'm going to cover about 10 studies that were presented at ASH in some detail. So the first paper is this one entitled Clonal Hematopoiesis with Somatic Mutations is a common age-related condition associated with adverse events by Jaswal, and was presented at ASH. And you can see here that this was a study that looked at DNA from some 17,182 individuals, and the blood, peripheral blood, was analyzed by whole exome sequencing. Some 160 genes that were currently mutated in hematologic malignancies or potential candidates to look for somatic variants. Previously, these genes were studied using single nucleotide variants or small insertion deletions. If a variant was present, it was analyzed for the association of hematologic phenotypes, survival, and cardiovascular events. Some 805 candidate somatic variants were identified from 746 individuals, and some 73 genes were identified for further analysis and study. And here in this slide, you can see that DNMT3A, TET2, and ASXL1 mutations were those mutations that were most commonly identified in these 17,000 plus patients. You can see that the variants, or that these gene mutations occur in relationship to increased age of patients, that they are rare to identify them in patients under the age of 40, but there is increasing frequency as patients get older, and you can see it ranges from 9.5 doubles up to 18.5% in those greater than 90 years of age. You again can see down here at the bottom of the slide the total number of patients that were studied obviously gets smaller as patients age, and there is only about 86 patients in the 90 to 99 age category. And this slide looks at the development of hematologic cancers with respect and in association to these somatic variants. And it's not just related to DNMT3A, TET2, and ASXL1, but all the somatic variants that were identified. So here there are two cohorts that are identified here. There's a Hopkins cohort and a multi-ethnic, there's a Jackson Hospital cohort and a multi-ethnic cohort that were identified. And you can see that with respect to gene mutations, there's a higher incidence of association of hematologic malignancies in the presence of gene mutations. And here you can see the breakdown, increase with respect to hazard ratio in this forest plot for the patients in the individual, individuals in these individual cohorts. So the JHS and the MEC cohort you can see there was a higher incidence of mutation and associated malignancy in the MEC cohort. When individual variant allele frequencies were looked at, meaning the frequency with which the mutation was identified in a specific individual, higher frequencies, in this instance greater than 0.1, were associated with ever-increasing risks of hematologic malignancies in both of these cohorts. And so there was greater sensitivity in patients who had variant allele frequencies that were higher in these particular mutations. In panel B here, you can see that there is an association of developing a hematologic malignancy in patients who have mutations, somatic mutations, compared to those who do not have mutations. And in this panel C, this looks at variant allele frequencies, and in patients who had a hematologic cancer versus those that did not, there was a higher variant allele frequency for somatic mutations in patients who developed hematologic cancer. So the finding of somatic mutations increased the risk of developing a hematologic malignancy, as you can see here. But this risk was not restricted to developing hematologic malignancies. There was also a higher incidence of type 2 diabetes, increased risk of incident coronary heart disease, and ischemic stroke. So these somatic mutations conveyed a higher risk or higher degree of mortality related to any one of these hematologic malignancies, in cardiovascular disease, and diabetes. So the conclusions were that clonal hematopoiesis is observed with greater frequency in older populations. Individuals with clonal hematopoiesis are at increased risk of developing hematologic malignancies, which is not limited to MDS and AML. In the presence of these mutations, these G mutations observed related clonal hematopoiesis may not be sufficient as a diagnostic criteria for MDS. And this is an important point, as the presence of being able to identify somatic mutations in individuals becomes more prevalent in the community, with more commercial laboratories providing this type of testing. Presence of a mutation alone is not sufficient in the absence of other criteria to convey a diagnosis of MDS in a patient. So carrying this theme forward now about novel sequences and sophisticated molecular testing, next study is looking at next-generation sequencing, profiling of patients with so-called idiopathic cytopenias of undetermined significance, the so-called ICUS, and it identifies a subset of patients with genomic similarities to lower-risk MDS patients. And in this study, they looked at patients with ICUS. These are patients with unexplained cytopenias that don't meet the minimal criteria for MDS. It's been identified in some 12 to 60% of patients who have MDS having this antecedent period of cytopenias. And here in one particular study, from a few years ago, about 26% of these ICUS patients showed evidence of clonality by Humira or X chromosome inactivation. And in a small subset of patients, some went on to develop AML, whereas it was not seen in those without the clonality. So the presence of an abnormal clone or a clone in patients may carry significance for patients. So in this study, the brown represents patients with the idiopathic cytopenias, and the orange represents patients with low-risk MDS with a diagnosis confirmed by morphology of low-risk MDS, meaning either low or intermediate 1. So in patients where cytogenetics alone was looked at, you can see that 14% of these patients had a genetic abnormality according to whether it was IGUS or the low-risk MDS patients. When sequencing was looked at, it identified further a larger group of patients who had a genomic abnormality, and in a much higher percentage of patients had the same abnormality or had an abnormality. So it identified a much larger patient population that with cytogenetics alone would identify by using next-generation sequencing. When the two were combined, cytogenetics and next-generation sequencing, you can see that it really doesn't add much more to sequencing alone. So the addition of cytogenetics adds something, but not a whole lot beyond what the next-gen sequencing can add. So I'd certainly say that in the next few years, we're going to see a lot more genomic analysis done by next-generation sequencing and other molecular techniques to identify abnormalities in patients. And so this will be an important thing to look for in the future. Again, looking at molecular analyses, this next paper looks at p53 mutation status. And in this group, they looked at patients who had complex karyotypes and noted that an analysis of p53 mutations subdivided these patients with complex karyotypes into distinct subgroups or risk groups. And this was an analysis of data sets from an international working group on MDS molecular prognosis. And here you can see cytogenetics are prognostic in MDS. The poorest prognosis are patients who have complex karyotypes defined as 3 or more abnormalities, p53 mutation, or a monosomal karyotype. Mutations of p53 have been strongly associated with the presence of complex karyotypes, but there have been some contradictory findings relative to whether p53 mutation is an independent prognostic variable. So this study looked to try to understand the relationship between the presence of p53 mutations, the number of chromosomal abnormalities, and some of the clinical features. And this is work that was presented and led by Behar and presented at ASH. So here you can see that in patients with complex karyotype, presence or absence of p53 mutation, and the presence of a p53 mutation was associated with a much poorer outcome for patients compared to those patients who did not have a p53 mutation. And this was statistically significant, the median being about 10 months versus 20 months overall survival between the two groups. These patients were subsequently broken down into subgroups, looking at p53 associated with other particular abnormalities. So here, this is the subset of patients that had a p53 mutation among patients who had a complex karyotype. There, amongst these patients with a complex karyotype, about 76 had a monosomal karyotype as part of that complex karyotype, and about 70% of patients had 5 or more karyotypic abnormalities. So here you can see the overlap in this Venn diagram, and there were about almost 40% of these patients were so-called triple positive, meaning they had a p53, a monosomal karyotype, and 5 or more abnormalities. And there were 14% of the patients who had a complex karyotype but had none of these, neither p53 or monosomal or 5 or more. And then you can see within the subgroups of these curves, you can see the numbers of patients that fell into these various subgroups. And the value in this study is looking at the following. Both with respect to in terms of univariate, multivariate analysis, the presence of a monosomal karyotype versus not, and a multivariate analysis did not have substantial impact. but having more abnormalities, 5 or more versus 3 or 4, did have an influence on overall survival. Here's the hazard ratio, as did the presence or absence of a p53 mutation, again, associated with a poor outcome. And then they looked at patients who either had a double negative, so 14% I mentioned had a triple negative. These are patients who have a double negative compared to those who had a single positive or a double positive on that prior slide. And here you can see the differences in the median survivals amongst these subgroups. So the more of these abnormalities, either p53 complex with 5 or more abnormalities or a monosomal karyotype, 2 of those 3 was associated with the poorest prognosis. Absence of those was associated with a better prognosis. So again, this is just looking at the value of p53, and here you see the median survivals for these respective curves. So the significance in this study was that p53 was an independent prognostic variable for patients with MDS. It highly enriched in MDS patients with complex karyotypes. It appeared to dominate over a monosomal karyotype as an adverse prognostic indicator. There are some caveats here. There are patients who have a small variant allele fraction of p53 abnormality in a number of samples, and this may represent a DC subclone, which may be insufficient in quantity of the mutation to alter the clinical measures, but may be a clone that ultimately is either responsible for treatment resistance or may give rise to rapid disease progression. So more work needs to be done, and p53 is going to have to be sequenced with respect to the types of abnormalities, because we'll need to see whether all the types of various mutations of p53 are all equal, and whether they have an equal prediction on outcome. But it does seem to be important in predicting patients who have complex karyotypes with respect to qualify the outcome for patients with complex karyotypes. This next study was a late-breaking abstract. It was a randomized phase 2 trial, an intergroup study led by SWOG. Kale Sikaris presented these data. Combination trial of 3 arms. Patients were randomized to receive either azacitidine plus lenalidomide, or azacitidine plus vorinostat. You can see the doses and schedules here. Standard dose and schedule of azacitidine was employed using lenalidomide 10 milligrams daily for 21 days, or using vorinostat 300 milligrams BID on days 3 through 9. 276 patients were rather rapidly accrued in this study. Primary endpoint was to look at overall response and look for an improvement of 20% over the baseline of azacitidine as a single agent. It was powered adequately to provide an answer for the primary objective. And here you see 282 patients were enrolled. The baseline characteristics were well distributed. Patients received a median of 23 weeks of therapy, followed for 9 months. And here you can see the CR rates amongst the 3 arms in this column here. And then the overall PR and hematologic improvement, and then the median weeks on treatment. And so you can see here, relatively modest number of weeks on treatment for these patients, suggesting that the patients exited the treatment group somewhat relatively quickly, in all 3 arms. And this is the relapse-free survival curve of azacitidine, aza plus lenalidomide versus aza plus vorinostat. There was a trend in favor of the aza plus vorinostat, and further follow-up will be required in order to determine whether there is a significant effect from the aza vorinostat arm with respect to relapse-free survival. So The conclusions were the objective response rate was similar for AZA monotherapy compared to the two arms. There were differences in the type of response. It may be partly due to differences in the way the protocol called for bone marrow follow-up for patients, and there was a non-significant signal in favor of verinostat with AZA, but longer outcome follow-up needs to be done in order to draw conclusions. I would say that we'll need some additional follow-up before we can make conclusions about this study, which I think, at least on the face of what was presented, is disappointing in the sense that one, azacitidine's overall response rate was much lower than has been described in previous trials at 36%. The responses for the other two combinations were lower still, and that neither of the combinations seemed to be better than monotherapy. The toxicity of the combinations may be at play here, may be a challenge for us as we develop further combination trials in the future. This next study is talks about or looks at the incidence of treatment of MDS in the U.S., treatment approaches, optimization of care, and the need for additional therapeutic agents. The study was led by Aaron DeMarcos and presented at ASH. The incidence of MDS is heterogeneous, and one way to look at the incidence of MDS and understand treatments in the U.S. is to look at medical claims information, which is a common way of looking at this. And in this study, medical claims were examined over a 3-year period. What was identified was that in a 3-year period, 107,000 patients with MDS were identified, and here you see the split of the types of treatment these 107,000 patients received. So 86% of all of these patients received either watchful waiting or just supportive care, meaning erythropoietin-stimulating agents or growth factors such as Neupogen or filgrastim. Only 14% of patients received so-called active treatment, which would be HMAs or lenalidomide, or HMAs, lenalidomide, combined with ESAs and cytokines. So only 14% of these patients received active intervention, which is interesting in terms of the numbers, relatively small numbers of patients. So with respect to HMAs, for azacitidine, 6 cycles is now the recommended numbers of cycles that a patient should have before making a final determination with respect to response or not, unless there's clear-cut progression early on. And the numbers of patients that normally progress on AZA are relatively small. So what these data show us is that 1/3 of the patients dropped out after cycle 1, and more than half the patients were finished with treatment, taken off HMA-based therapy by the end of 3 cycles. So disappointing that more than half the patients received well less than the optimal number of HMA-based cycles, and only 31% patients actually received HMAs out to 6 cycles, and decitabine had similar decline after the first cycle. So this shows a relative small number of patients that get out to 6 cycles. And the conclusion was that the total number of patients coded, 107,000 in 3 years, calculates out to 34,000 patients per year, is similar to what has been identified in other databases. Majority of patients are not treated with an optimal number of cycles of an HMA. The average physician in the U.S. treats a limited number of patients, about 2.8 patients with MDS, and this may reflect and influence treatment decisions. Early discontinuation or failure of HMA therapy accentuates the poor outcome. And after patients were taken off study, 80% of the patients went back to receive just watchful waiting. Now, we know that in patients who fail in HMA therapy, the median survival is 4 to 6 months following failure of an HMA therapy. And moving back to watchful waiting would just enhance this poor outcome. So we certainly need an effective second-line regimen, and we need to be able to optimize the use of HMAs in patients with MDS. So this was kind of striking analysis and conclusions regarding 3 years' worth of medical claims data. The next study is a phase 1, phase 2 study of a combination of oral rigosertib plus azacitidine in patients with MDS and acute leukemia. The phase 1 data were presented at ASH. Rigosertib is a small molecule that targets PI3 kinase, POLO1 kinase pathways, promotes arrest of cells in G2M, and interferes with BRAF and RAS signaling. And in vitro combination of rigosertib and azacitidine acts synergistically to inhibit growth and induce apoptosis. And in vitro, at least, the effect appears to be sequence dependent, with rigosertib having to be given first, followed by azacitidine. So in this phase 1 study, 18 patients with MDS and non-proliferative AML were treated. Here you see the breakout of these patients, 10 with MDS, 8 with AML. The patients were treated in 3 cohort groups, 140 milligrams twice daily, 280 twice daily, and then the third cohort, 560 in the morning, 280 in the evening. AZA was administered for 7 days at the standard dose and schedule. And here you can see the results. 18 patients treated, median age was 70.5. 11 of the 18 were transfusion dependent. 6 of the patients at the time of the presentation had received fewer than 4 cycles of treatment or too early to evaluate. 6 patients who came off study, and here are the response data. So 4 patients achieved an incomplete response, meaning there was improvement in blood counts, but not sufficient to qualify as a CR. Additional 5 patients beyond these CRI had less than 5% blasts in the marrow, so a marrow CR. 2 had stable disease, 1 progressive disease, and 6 were not evaluable for response. 2 patients who had failed prior HMA therapy responded to the combination, and this was an important observation in this relatively small study, that patients who have HMA failures can respond to the combination, which is an important observation. So the combination of oral rigosertib at 560 and 280 milligrams BID is the recommended phase 2 dose, along with the standard azacitidine. The AE profile didn't differ significantly from that of azacitidine alone. And interestingly, the rigosertib in combination with azacitidine appeared to be tolerated better than the rigosertib alone, and on a 21-day schedule that's been used in patients with lower risk MDS. The data from the phase 1 suggests activity in patients after HMA failure, and the phase 2 segment of this study is underway and hopefully will be reported at the ASH meeting in 9 months. The next study is the phase 3 study of overall survival and subgroup analysis from a randomized phase 3 study of intravenous rigosertib versus best supportive care in patients with higher risk MDS after a failure of a hypomethylating agent. This is the so-called ONTIME study or ONTIME trial. There are no approved treatment options for patients with MDS who fail in HMA. And rigosertib, as I mentioned, inhibits is a multi-kinase inhibitor. In this study, 0421, was conducted in the U.S. and in Europe. at 87 sites in the U.S., 5 in 5 European countries, looked at the efficacy and safety of rigosertib, and the primary endpoint was overall survival. 299 patients were accrued in this study, randomized 2-to-1 to the rigosertib treatment compared to best supportive care. And best supportive care included transfusions and antibiotics, but also allowed for low-dose cytarabine, which was utilized in about 1/3 of the best supportive care patients. Analysis was done after 242 deaths. The demographics were well balanced between the two groups. 64 and 57% of these patients had primary HMA failure. The median duration from the last HMA therapy to entry into the study was 8.8 months. The intensity of dose was 92%, so thus patients received substantially the intended amount of drug. And the adverse events are listed here, some GI toxicity, fatigue, and some anemia were the most common. Here's the primary endpoint. In this case, there was an improvement in survival in favor of the rigosertib group compared to the best supportive care group, 8.2 versus 5.9 months, but this did not reach statistical significance. Here you see the medians, and the curve separated for the first about 15 months, and then there was some crossing here at the latter tail of the study. The overall survival for patients who have primary HMA failure is shown in this panel here, where the overall median survival was 8.6 versus 5.3 months, and this was statistically significant with a hazard ratio of 0.69 and a p-value of 0.04. So this subgroup this appeared to benefit with respect to survival. In this forest analysis or forest plot, you see the hazard ratios, and you can see that there are 4 subgroups that seem to benefit. Those patients with primary HMA failures, those patients who received HMA for less than 9 months, patients who are less than 75 years of age. Now, this is a continuous variable. So I should mention at this point that this was looked at as continuous variable, and patients up to the age of 80 showed this benefit. Over the age of 80, the benefit disappeared. So even though this is represented historically as less than 75 and greater than 75, there's some fluidity because of the continuous variable nature of this parameter. And then those patients with IPSR, very high risk, also benefited significantly with respect to survival in this analysis. So the primary, or the conclusions from the ONTIME trial, the primary endpoint did not reach statistical significance. Rigosertib-related, treatment-related improvement in overall survival was noted in following well-balanced groups: those with primary HMA failure, IPSR, very high-risk patients, and those patients with either monosomy 7 or trisomy 8 also had significant survival benefits in this subgroup analysis. The continuous IV infusion had a favorable safety profile. So although this trial didn't meet its primary endpoint, further analysis and further studies involving rigosertib are ongoing. A new phase 3 trial is planned in the specific subgroups that were identified as positive and in combination studies. Moving ahead, in the last few studies, the efficacy and safety of lenalidomide versus placebo in red cell transfusion dependent patients with low and intermediate 1 risk MDS without deletion 5q, unresponsive or refractory to erythropoiesis. This is the 005 study that was conducted in Europe and presented at this ASH. So here, patients are randomized to receive lenalidomide or a matching placebo, and the primary endpoint is looking for red cell transfusion independent according to IWG, defined by greater than 8 weeks of erythroid response over the term of the study. And the background here is really comparing lenalidomide versus placebo in red cell transfusion-dependent patients in low and intermediate risk MDS, unresponsive to ESAs. Patients were randomized 2-to-1 in favor of lenalidomide with 10 milligrams as the starting dose. And here you can see the results. This is the intent to treat population of 239 patients. 26.9% of patients became red cell transfusion independent for more than 56 days, compared to only 2.5% in the placebo. The median duration of transfusion independence is 32.9 weeks, and 17.5% of patients maintained their transfusion independence for more than 6 months. And the conclusions was that it was lenalidomide therapy was associated with a significant achievement of transfusion independence in 26.9%. 90% responded within the first 16 weeks. These data are consistent with the transfusion independence rate in the MDS 002 trial that was reported on by Asralaza several years ago, run in the U.S. And the overall safety profile is consistent with the profile of lenalidomide as already established. So further evidence of lenalidomide efficacy in about 27% of patients with lower risk disease who are transfusion independent and fail an ESA. The last couple of studies involve a novel molecule, the ACE-011 or ACE-536. These are fusion proteins using the Fc domain of a human IgG antibody linked to an extracellular domain that binds with and blocks the activin 2 receptors. Two different molecules. One molecule, the sotatercept, has effects on both heme and bone, whereas the 536 molecule only on heme effects. So the sotatercept is the first one we're going to describe. It binds to the activin A receptor, neutralizes the activin A and GDF11 ligands for up to a month, and these two molecules or receptors lead to suppression of erythropoiesis, and binding or inhibitory binding to these receptors leads to restoration of differentiation. It promotes differentiation of osteoblasts and of erythropoiesis. And so in this first study, it's a phase 2 study involving patients with lower intermediate 1 risk disease, and patients who had no response, loss of a response, or a low likelihood of response to an ESA were eligible. And the primary objective here was safety and efficacy with respect to erythropoiesis in patients who were transfusion, and the secondary objective was to see how many patients would become transfusion independent for more than 8 weeks. Dosing was administered subcutaneously once every 3 weeks in escalating cohorts. 54 patients were treated. You see the low-risk categories here, about a third low risk, 63% intermediate 1, 45% had a high transfusion requirement versus 17% that had low transfusion requirement, defined by either being more or less than 4 units of red cells in 8 weeks. And then you see the breakout here with respect to prior MDS therapy. Most of the patients had ESAs, about half had hypomethylating agents, and almost half had prior lenalidomide therapy. Overall results here are shown. Improvement by IWG 2006 was seen in 45% of the patients. 11% of patients with high transfusion requirements achieved red cell transfusion independence for more than 56 days. So only 5 out of 45 here. higher percentage, 5 out of 8, with low transfusion requirement, achieved red cell transfusion and had a mean hemoglobin increase of 1.5 grams, sustained for 8 weeks. Overall, the drug was well tolerated, with a few significant adverse events. Here again, you can see the efficacy. So these are the cohorts, and there was a higher response rate in the cohorts with the higher dosages of the sotatercept, and you can see the overall response rate, but nevertheless, overall, 11% of patients became transfusion independent in this study. And you can see for the patients here in low transfusion burden patients that the responses were seen in the higher, the cohorts with the higher concentrations of sotatercept. So safety, it was well tolerated. 37% reported more than one treatment-related adverse event. Fatigue, headache, decreased appetite were the common ones. 65% discontinued treatment, 28 of the 35 due to lack of efficacy, and there were some unusual hemolytic anemia in 2, hypertension in 3, muscular weakness in 2 patients. So some unusual adverse events described, but overall it was well tolerated, and further studies are required. The last study looks at ACE-536 in patients with low and intermediate risk MDS. Again, this is preliminary results from a phase 2. And here you can see that, again, this is this ligand blocks receptors in the TGF-beta superfamily, which is an inhibitor of hematopoiesis. It binds to the sotatercept, binds to the activin receptor domain, inhibiting it, and the mechanism of action is distinct from erythropoietin, acts on late-stage erythropoiesis to increase circulating mature red cells. In this study, lower to intermediate risk MDS patients were eligible, either higher or lower transfusion burden. Evaluation of the erythroid response was a response criteria along with safety and tolerability. And then a further inclusion criteria other than transfusion was EPO levels greater than 500. And in this study, there was no prior HMAs or lenalidomide allowed. It's an ongoing study. There were 8 cohorts. Patients received up to 5 doses every 3 weeks with a 3-month follow-up. And here are the preliminary data for 26 patients. And you can see that there were patients with lower transfusion requirements. Here, 0.9 units for 8 weeks in the lower transfusion, 6.3 units in the higher transfusion. And for the hemoglobin response and lower transfusion requirements, you can see that there was a smattering of responses, 7 overall in the cohorts that were administered in the low transfusion burden population, which is really summarized here on this slide. In the low transfusion burden, 2 out of 5 patients in the higher dosing cohort responded. 5 out of 12 in the higher transfusion responded. And overall, this is for all patients treated, 41%, 7 out of 17, when one adds together both the lower and higher transfusion burden patient population responded. And one note by IWG, for lower transfusion burden, become transfusion independent with a 1.5 gram or greater rise in hemoglobin. And for the high transfusion burden, all that's required is a reduction by 50% in the transfusion requirement over an 8-week period. And here you can see maximum increase in hemoglobin in patients with low transfusion burden, and the higher concentrations are associated with a greater rise in the transfusion burden. So the results of this study shown here, 7 of 9 in the high transfusion burden patients had a 50% or greater reduction in transfusion requirement. 5 of 6 amongst these patients became transfusion independent, with some increase in neutrophils in patients. And overall, the study, the agent was well tolerated, and there were some GI adverse events and some bone and myalgia type adverse events in these patients. So based on this preliminary results of this ACE-536 study, additional studies will be undertaking and are ongoing.
Thank you very much, Dr. Silverman.